Hello.
Hello.
You've handed us a really fascinating stack of sources today, pulling back the curtain on frontline healthcare in India. We have excerpts detailing the training of auxiliary nurse midwives, ANMs, directly from their syllabus, some material introducing the crucial role of community health officers.
Right, the CHOs.
Especially within India's massive Ayushman Bharat program and the health and wellness centers, plus some, deep dives into the practicalities, the data management support structures at this level.
Yeah, it's a look right at the core, isn't it? How healthcare services are actually meant to reach people, at the community level.
Exactly.
Our mission in this deep dive really is to take these documents and just unpack them. We want to understand the foundation laid by the training, how key roles like ANMs and these newer CHOs fit into the national strategy, and get a sense of the nuts and bolts, the systems, the data, the teamwork that are supposed to make it all, work on the ground.
Right. Understanding the mechanics of delivering comprehensive primary care where people actually live. Okay, let's unpack this then.
Let's do it.
Let's start with the training, because that's where it all begins for workers like the ANMs. The syllabus you provided gives us a really detailed look.
It really does. It shows you the rigor involved. I mean, the practical exams alone have some striking requirements.
Yeah.
We saw details like practical exams being limited to just 10 students per day.
10 a day. And this part really stood out to me. All practical exams must be conducted in clinical areas, actually on patients.
Right. Not simulations.
No, this isn't simulation. It's assessment in a real healthcare setting.
That emphasis on hands-on, real-world competency is just so clear. And who's doing the assessing? The practicals are jointly done by one internal examiner and one external examiner.
Okay.
And that external person has to be a BSc nursing teacher with at least 5 years of experience.
So an experienced external perspective, that adds a layer of standardization,
Yes,
I suppose.
Definitely. And expertise?
And then there are the attendance rules. Wow. To even sit for the exams, you need 80% minimum attendance for theory and practical in each subject.
80% minimum, yeah.
But the kicker is for the final certification or diploma, you need 100% attendance in each practical area.
100%.
That's quite something.
It is. That 100% practical attendance is quite a commitment, and it really underscores how critical mastering those specific hands-on skills is considered for this role.
Yeah, non-negotiable practical learning.
Exactly.
Absolutely. And the sheer volume of training hours reflects this intensity too. The syllabus breaks down hours for different areas. Community health nursing is 170 total hours.
120 theory, 50 demo.
Midwifery is a substantial 360 hours.
That's a big one. 200 theory, 160 demo.
And child health nursing is 180 hours. These are significant chunks of time dedicated to core community health areas.
Yeah, they are. But what's really fascinating, I think, is when you look beyond just the clinical hours and see the breadth of topics covered. It goes far beyond, basic medical procedures. They're taught to understand social factors like class, caste, race, and how these things actually influence health outcomes.
That's key. They learn about family structures, different marriage types, relevant laws in India. They're trained in methods of community need assessment.
Like using surveys, questionnaires.
Those kinds of tools.
And importantly, counseling. They're trained in the concepts, principles, techniques, identifying community needs for counseling and understanding their specific role as an ANM counselor is built right in.
Okay, so it's not just delivering services, but also support.
Exactly. They also cover identifying health conditions needing rehabilitation and learning about available community resources. Nutrition is key too.
Oh, yeah.
Essential nutrients, food classification, nutritive values, planning balanced diets for different age groups, it's all in there.
Mental health is addressed too, right?
It is. Identifying signs of mental illness, early detection and referral, guiding home care, counseling for prevention, and knowing when and how to refer emergencies.
That's crucial.
And specific training on old age care, the aging process, needs, problems, home care, rehab resources, that's covered.
And infection control. Sounds fundamental.
Absolutely detailed. Causes, microorganisms, transmission, body defense immunity, vaccines, proper specimen collection.
Blood, sputum, urine, stool.
Right. Safe disposal, labeling, principles and methods of disinfection, sterilization. It's thorough.
They cover epidemics too.
Yep. Definitions, causes, how to do an epidemic inquiry and mapping, and the ANM's role in relief work.
Okay.
And essential first aid. Everything from minor cuts and burns to fractures types, first aid, immobilization, transport in life-threatening conditions like severe bleeding, drowning, strangulation, suffocation.
Wow. Covers a lot of emergencies. And midwifery.
Comprehensive. Male-female reproductive organs, conception, fetal development, the female pelvis, muscles, normal delivery processes, newborn care. Women's health is a major focus. Identifying specific problems, guidance on reproductive health issues, participating in family welfare programs.
What kind of specific topics?
Things like cervical and breast cancer screening, mentioning pap smears specifically. Conditions like fibroids, menstrual disorders, menopause, STIs, RTIs, causes, symptoms, treatment, prevention, education. It's quite specific.
And finally, you mentioned career development.
Yeah, the syllabus even includes that. Emphasizing continuing education, methods for self-development reading, summarizing, comprehension, interacting with the community, improving speaking and writing in local languages and English.
Looking at this incredibly diverse syllabus, what strikes me is they're being prepared for a role that's much more than just a medical technician in a clinic.
Oh, absolutely.
It's like being a multi-skilled community health pillar who understands the complex social, environmental, personal stuff that affects health.
That's a great way to put it. It really reflects the need for these frontline workers to navigate a huge spectrum of health and social challenges. They're meant to be comprehensive health navigators and service providers right where people live.
So that's the intense foundation of ANM training. Now, how does this fit into the larger system? Specifically within India's big healthcare initiative, Ayushman Bharat, our sources introduced the Community Health Officer, the CHO.
Right. The CHOs are, well, they're a relatively new group of non-physician health workers, and they're designed to be crucial players in delivering the specific essential package of services called Comprehensive Primary Health Care, or CPHC.
Okay, CPHC. And this is all happening under the Ayushman Bharat umbrella.
Exactly. Ayushman Bharat is this major government program with some really ambitious goals. Addressing the disease burden, significantly cutting out-of-pocket spending for families.
Which is huge in India.
Huge. Improving how people use public health centers and ensuring continuity of care. It's a big vision.
And how does it work? The sources mentioned two parts.
Yeah, a two-pronged approach. One part is upgrading the infrastructure, taking 1.5 lakh sub-health centers and primary health centers and turning them into Ayushman Bharat Health and Wellness Centers. HWCs.
Okay, so HWCs are the delivery points for the CPHC.
That's the idea. And the second part is Pradhan Mantri Jan Arogya Yojana, PMJY.
Right, the insurance part.
Essentially, yeah. Financial protection. Health insurance offering up to 5 lakh per year for free secondary and tertiary care for about 40% of India's lowest income families.
So, upgrading facilities and providing financial safety net.
That's the combination. And the CHOs are absolutely central to that HWC component.
Oh, so?
At the HWC, the CHO is meant to lead the primary healthcare team. They provide clinical management, ambulatory care, and critically, they serve as the key link for coordination.
The coordinator?
Yeah, they're the ones supposed to maintain continuity of care for the community by connecting them to the broader health system when needed.
That leadership role sounds significant. Who else is on that team at the HWC?
The team typically includes the CHO, the multipurpose workers, or MPWs,
Okay.
and the accredited social health activists, the ASHAs.
Ah, the ASHAs. We hear a lot about them. So the CHO leads this team of existing MPWs and HADers.
That's right. And the sources mention that understanding the distinct roles, but also the potential overlaps between MPWs and ASHAs is crucial.
Makes sense.
So the team can coordinate effectively and make sure all the essential services actually get delivered. It implies a need for, clear communication and role definition within that local team.
Got it. The ASHA's role is particularly detailed in the sources, isn't it? Shows how deep they are in the community.
Oh, absolutely. She assists with referrals, HWC, PHC, CHC, first referral units. She's providing community-level care for common stuff like diarrhea, fever, caring for sick newborns, childhood illnesses, first aid.
And the sources mention DOTS provider for TB.
Yes, designated DOTS provider. So she's trained to give that supervised tuberculosis treatment right in the community.
Wow.
And she's a depot holder for specific health products, carries an approved drug kit for essential medicines, plus promoting household toilet construction linking health and sanitation directly.
Her daily activities sound intense.
Very community-focused. The sources specify home visits, about 2 hours a day, 4 to 5 days a week, prioritizing disadvantaged families. And these visits now include promoting newer services, NCDs, mental health, elderly care. There are even recommended visit frequencies.
Like
at least monthly visits for homes with pregnant women or young children, and more than 6 visits for newborns. It's structured.
And she's involved in distributing bed nets, Doing initial inquiries if there's a maternal or child death.
Verbal autopsies, yeah. Organizing community meetings for health awareness, keeping community-level records. It's truly multifaceted, deeply integrated at the household level.
Okay. And the MPW's role, how does that fit in?
Based on the sources, it's largely supportive. Assisting the CHO and HO, providing care if needed, especially if the ASHA can't cover something, helping with home-based newborn or childcare management, assisting with things like bed net distribution, sort of the backbone support.
Gotcha. So you have this coordinated team aiming to deliver services across different levels. What does that look like service-wise?
Well, services are delivered at the community level first, things like population listing, health promotion, managing minor illnesses, teleconsultation, counseling, drug distribution, even getting specialist advice sometimes.
Right, reaching out.
Then there's the care provided at the HWC, the subcenter itself. And finally, care at the referral center level, the higher facilities like PHCs or CHCs if RMNCH plus A, that's reproductive, maternal, newborn, child health, plus adolescent health. Screening and management for non-communicable diseases, NCDs.
The chronic stuff.
Right. Infectious diseases, elderly care, palliative care, eye, ear, nose, throat problems, oral health, dental pain, emergency first aid. It covers a lot.
And this shift towards comprehensive care is necessary because the health landscape itself is changing.
That's what the sources highlight, a significant move in the disease burden. While infectious diseases and maternal nutritional issues haven't gone away.
No, definitely not.
There's this clear rise in NCDs, cancer, cardiovascular disease, diabetes, respiratory diseases. These now account for a huge chunk of deaths, many happening prematurely.
But as you said, maternal and child mortality is still a challenge in some places. Things like MDR-TB, hepatitis, dengue, chikungunya are still serious threats.
Exactly. It's not a simple swap. It's a layered challenge, which is why you need that comprehensive approach. You can't just focus on NCDs and forget everything else.
Makes sense. Frontline workers need to be equipped for all of it.
Precisely.
One key pillar of this CPHC that really stood out in the sources was health promotion. What does that actually involve at the HWC level?
Yeah, health promotion is defined with a really clear goal: empowering people to make positive lifestyle changes.
Okay.
The aim is reducing the risk of getting severe diseases in the first place, preventing complications if you're already diagnosed, and ultimately reducing that financial burden on families from healthcare costs.
Right, the out-of-pocket expenditure we mentioned.
Exactly. And the sources distinguish this from primary prevention, which is specifically about stopping risk factors from even emerging. Examples given were promoting exclusive breastfeeding or using helmets. Fundamental practices with big health impacts.
Got it. So what kind of topics do they promote?
They list targeted topics for different groups: family planning and STIs, RTIs for eligible couples. For adolescents and youth, it's diet, lifestyle, substance abuse, gender-based violence, mental health. And for infants and children, feeding, immunization, wash water, sanitation, hygiene, early development, deworming. It's tailored messaging.
And how do they get this message out? What resources do they use?
They leverage existing community structures, things like patient support groups, the ASHAs themselves, Anganwadi workers, the village health, sanitation nutrition committees, VHSNCs.
Okay, good committees.
Monthly community mobilization efforts, multi-sectoral coordination, and those scheduled village health, sanitation, and nutrition days, VHSNDs. It's really a network approach.
Tell me more about the patient support groups. That sounds interesting.
Yeah, they're highlighted as a specific strategy. The purpose is crucial: reduce stigma, increase acceptance and adherence to treatment, especially for chronic conditions.
Right, which can be hard.
Very hard. The benefits are improved understanding, better coping skills for patients and their families. CHOs, with ASHA's help, are actually meant to identify people with high prevalence conditions to form and facilitate these groups.
And how do they facilitate them? Are there guidelines?
Yes. Key principles mentioned are: they must be open to all. Discussion should be facilitative guiding, not directing, requiring communication and leadership skills from the facilitator. Empathy and care are essential. The first meeting involves introductions, defining the voluntary roles attending, helping others, sharing knowledge, listening, working together. It's about building a community of support.
That sounds potentially very powerful.
It could be, and ASHAs are directly involved here too, listening to the community, identifying those at risk, mobilizing people for screening, helping with health camps and VHSNDs, and helping disadvantaged folks access the HWC services.
And their role in follow-up seems critical.
Absolutely vital for ensuring people stick with treatment plans, especially for chronic stuff like NCDs, mental illness, TB, and for vulnerable groups like pregnant women and newborns. That follow-up connects the HWC services right back into the home.
Okay, so we've got the training, the team structure, the services, the health promotion. How is all this managed and tracked? What about the operational side?
Right, the practicalities of running an HWC. This includes inventory management, medicines, reagents, consumables, making sure requisitions go in on time, displaying the essential drugs list, maintaining equipment, furniture, the basics. There's also mention of untied funds, a specific amount, $50,000 allocated per HWC.
Okay, some local budget flexibility.
Exactly. But the sources stress the need for proper utilization, record keeping, accounting, and submitting expenditure and utility certificates annually. So flexibility with accountability.
And a really foundational step you mentioned earlier was population enumeration.
Yeah, population enumeration and household listing, done with ASJ's help, that's how they understand the community they serve, register everyone in these family folders.
Family folders.
Okay. And this demographic data is then meant to be transferred to an IT system at the subcenter level, creating a digital record for the HWC's population.
That sounds like a huge data task. And the list of other recording formats used at the SHC, HWC level seemed quite long, too.
It is extensive. Shows the amount of data being generated, or at least intended to be generated. Registers for RCH, birth, death, infectious diseases, malaria, JSY.
That's the Maternal Child Health Scheme.
Right. Accounts, water quality, the NCD family folder CBAC, that's the community-based assessment checklist.
Screening?
Yes. OPD register, stock register, due list for services, VHSND supervision records, an NCD register, monthly meeting register. Phew.
That's a lot of registers. Really highlights the intense admin and record-keeping effort needed right there at the front line.
It does. And MPWs, CHOs, sometimes the PHC medical officer are involved in entering, checking, signing these records.
So how do they manage all this data? You mentioned IT systems.
Yes, several IT systems are supposed to support this. There's the integrated RCH register used by MPWs to register and track beneficiaries, often a separate register per village.
Okay.
Then there's ANM. That's an Android app designed to mirror the RCH register features.
Ah, digital version.
Supposedly.
Yeah.
Village profile, tracking eligible couples, pregnant women, children, monitoring, allows data entry on a huge number of elements, 245 according to the source. Uses the ANM's ID to log in. Aims to digitize some of that intense record keeping.
And for disease surveillance.
The Integrated Disease Surveillance Program, IDSP, it has a web-based app for early warning of epidemics. But what's interesting is that while it's a web system, the core reporting from the field still involves a paper-based weekly S-form filled by the MPW.
Still paper?
Yeah, sent to the PHCMO. With daily telephonic reporting added during outbreaks, it shows this kind of mix, old and new systems may be working in parallel.
Interesting. What about the main CPHC system?
Right, the CPHC IT system itself. This uses a national ID for individuals. The idea is to track services received across different levels, SHC, PHC, CHC.
Build a continuous health record.
Exactly. Individual health records showing past illness, treatment plans, follow-up needs.
And it includes data entry for that CBAC checklist.
Yes, for screening individuals over 30 for hypertension, diabetes, oral, breast, cervical cancer. It even includes a job aid within the system.
Job aid.
Yeah, to help workers with referral and counseling based on the CBAC results. Sort of built-in guidance.
And teleconsultation is part of this.
Integrated into the CPHC IT system, allows the SHC-HWC team to consult doctors at higher centers, the PHC-MO, or a designated hub for guidance on patient care.
So specialist advice without immediate travel.
That's the goal. A way to bring expertise closer.
Okay, and one more portal mention.
The HWC portal, a web-based tool specifically for states and districts to plan and monitor HWC operations, uses a national ID for the health centers themselves.
Monitoring the facilities.
Right. Tracks a wide range of details. HR, training, drugs, diagnostics, infrastructure, IT use, teleconsultation activity, wellness activities conducted, and core service delivery data enumeration. CBAC's done. NCD screening numbers.
And the HWC staff use it daily.
Expected to log in daily, yeah. Enter basic operational data like OPD footfall, drugs diagnostics provided, wellness activities done that day.
With all this data flowing in, data quality must be a huge concern.
Absolutely. The sources really emphasize this. Data is only useful if it's accurate and timely.
Right.
Two key aspects highlighted: punctuality and accuracy. Punctuality is critical because late reports just hinder evaluation and action. Clear deadlines are set. Monthly reports by the 5th, quarterly by the 20th.
And accuracy
Means the data has to correctly measure what it's supposed to. Involves checking for things like zeros or blanks where there shouldn't be any, investigating omissions if stuff is consistently missing, making sure the reported picture reflects reality.
Okay, so how is this whole complex operation training, service delivery, data collection overseen and hopefully improved? The sources talk about monitoring, supervision, even incentives.
Yeah, there's a multi-level monitoring structure described. The CHO monitors the immediate SHC-SHWC team,
Okay, local oversight.
while officials at the PHC, district, and state levels monitor the HWC-SHC functioning, layers of monitoring.
And what does the CHO's monitoring involve?
Supervisory visits, home visits, monitoring those VHS&D sessions we talked about. They use specific indicators. Table 5 in the sources gives examples to assess how the HWC is functioning, team performance, outreach effectiveness,
With the goal being.
improving service quality, using the monitoring data to make things better.
And those indicators in Table 5, they really show the priorities, don't they?
They do. Proportion of registered estimated pregnancies, women getting full ANC, which is defined quite specifically.
For checkups, tests, TT doses, IFA tablets, counseling.
Right. Immunization coverage for young kids, kids under 5 treated for diarrhea with ORS sync, kids diagnosed with pneumonia, TB patients getting DOTS.
Concrete health outcomes.
Exactly. And they also look at family planning indicators, like how many condoms or pills ASAICs distribute compared to their stock. Very practical measures.
Beyond just checking metrics, the sources also talk about supportive supervision. What's that?
It's described as a non-authoritative process, different from just ticking boxes.
How so?
It happens through visits, but the focus is on helping staff improve their knowledge, skills, performance, encouraging open communication, problem solving together.
So more coaching than policing.
That's the idea. It's phrased as being about helping work happen, not just finding faults.
Where does this happen?
Through village visits, monthly subcenter meetings, block-level PHC review meetings, it's meant to be a continuous developmental approach.
Okay. And to motivate performance, there are incentives.
Performance-based payments, yeah. The sources mention maximum annual incentives, $196,000 for MPWS-HAs and $1,080,000 for the MLH-PCHO.
Those are maximums. How does it actually work?
Well, the source notes that initially, these incentives are equally weighted per indicator. For the MLH-PCHO, it's up to $15,000 annually, broken down as $1,000 per indicator achieved.
Okay.
For MPWS-ASHAs, it's a monthly rate per indicator, mentioned as $3,000 a month and $5,000 a month, respectively.
The math between the monthly per indicator rate and the annual max isn't perfectly clear, maybe.
Yeah, the source isn't crystal clear on exactly how those reconcile, but the core principle is clear: linking a portion of pay to achieving specific, measurable health outcomes. Performance matters.
Got it. And finally, verification. How do they ensure the data is reliable?
Crucial step. Local verification is done by the PHC medical officer, checking against registers and IT systems.
Okay, internal checks.
But there are also options for external verification, using an existing call center to contact service users, maybe state-level surveys, or even an independent committee to certify service quantity and quality. Helps prevent disputes, too.
Right. So it's a pretty comprehensive system designed not just to deliver services, but also track, support, and incentivize the frontline workers doing the really hard work.
Exactly. And all these layers, training, data, supervision are aimed at addressing the actual health needs of the population.
And speaking of actual health needs, before we wrap up, let's just quickly look back at that specific data you found on mental health from the National Mental Health Survey of India, 2015-16.
Right.
This really adds context to why mental health is included in the ANM syllabus and the CPHT package.
The numbers are significant, yeah. The survey found a lifetime prevalence for mental and behavioral disorders due to substance use was pretty high, 22.4%.
Wow, nearly a quarter lifetime prevalence for substance use disorders.
Yeah, and specifically, alcohol-related disorders were 4.7%, tobacco-related disorders, 20.9%.
Those numbers alone show a major public health challenge right there at the community level.
Absolutely. Then you have mood disorders, lifetime prevalence 5.61%, current prevalence 2.84%. Depressive disorders make up a big chunk of that. 5.25% lifetime, 2.68% current.
And anxiety.
Anxiety and stress-related disorders, 3.70% lifetime, 3.53% current. Specific conditions mentioned include generalized anxiety disorder at 0.57% lifetime and current, and OCD at 0.76% lifetime, 0.32% current.
Seeing those kinds of prevalence figures, it makes the inclusion of topics like identifying mental illness signs, early detection, referral, home care guidance, prevention counseling, and the ANM syllabus seem incredibly relevant.
Totally. It directly aligns the training with the real community needs these frontline workers are likely facing every single day. It just underscores why a comprehensive approach has to include mental health.
So, pulling all of this together then, what does this deep dive reveal for you, the listener?
Well, I think it paints a picture of just the immense complexity and also the dedication involved in trying to deliver primary healthcare at the community level in a place like India. It highlights these absolutely vital, multifaceted roles played by different health workers, from the ANMs, whose rigorous training prepares them to be way more than just clinical assistants.
Right, handling social factors, mental health.
To the CHOs leading the HWC team, alongside MPWs and AHAs who are embedded right there in the households.
It definitely illustrates how a major national program like Ayushman Bharat is attempting a fundamental shift towards truly comprehensive care, trying to tackle not just traditional health challenges, but also that growing burden of NCDs and mental health issues.
And it shows the ambition to improve efficiency, accountability through all those layered IT systems, the detailed record keeping, structured monitoring, performance-based incentives.
You really get a concrete sense of the operational layers, don't you? From the strict practical exam rules and attendance sheets in training, to the daily logins of mobile apps like Animal and web portals for monitoring, the stacks of registers, the community meetings like patient support groups, the mandated home visits. It's a system designed to reach people right where they are,
aiming to deliver essential health services at the doorstep.
We've taken quite a journey today, digging into the training, the roles, the operational structures underpinning India's frontline healthcare system. It's just this vast, complex network, people, processes, technology, all converging on that goal of reaching communities, providing essential care, seeing the granular details of the ANM syllabus right alongside the huge scale program architecture of Ayushman Bharat. It really brings home the dedication, the diverse skills, the sheer organizational effort required from these frontline health workers and the system supporting them.
It's a powerful reminder of the human and systemic layers involved in public health. It really is.
So here's where it gets really interesting, I think, for you listening. Considering the enormous scale of the population, the incredible diversity of needs, environments across India, what are the most significant practical challenges these frontline teams probably face every single day, actually delivering this comprehensive primary healthcare vision effectively to everyone?
That's the million-dollar question, isn't it?
It is. And looking ahead, how might technology, or perhaps even deeper community involvement, continue to evolve to try and meet those immense challenges on the ground?